We are now going to move into fall prevention. Fall prevention is everybody's responsibility in Del Monte Assisted Living and Memory Care. From the caregiver to the med tech to management to kitchen aide to housekeeper. It's everybody's responsibility to keep an eye out for hazards that could potentially lead to falls. We're going to watch a video. This is done by the system, but it's a very informative video.
Who has the first line?
Shh, we're on. Good day to you. I am Professor Emma Fallendown.
Ah, yes, and I am Dr. Julius Tipover here with a warm welcome to Pitfalls. So, did you know as many as 75% of our nursing home residents fall each year, with an average of 2 to 3 falls annually for each individual resident?
Fall prevention is critical. We'll be exploring what we all can do to decrease these appalling statistics for falls, with a special look at the locations and circumstances that contribute to so many falls.
It's a perfect opportunity for me to present my solutions to this problem.
Your solutions?
It's really much simpler than you might imagine, and it all starts with STOP. S-T-O-P.
I wish he would. The people who provide care every day in settings like this know firsthand how critical falling can be to the health of the residents we care for.
Every year, approximately 1,800 people die from injuries related to falls in nursing homes. Of the many who survive them, well, the quality of their lives changes dramatically. Most become disabled, and the many more who worry about falling again. Those of us who work in nursing home care know just how important it is to prevent falls. The health of our residents depends on it. Falling has many consequences. Injury and death are the most obvious ones, but fear of the next fall has its own costs. Residents often begin to withdraw from their typical routines and activities, which in turn increases their risk for additional falls.
So, what can you do, and what is STOP all about? Well, STOP stands for Stop, Think, Observe, and Prevent.
It's easy for anyone to fall into a comfortable job routine, but it's critical to be on guard for fall hazards the moment you start your day and to remain alert all during your shift. We have to be thinking constantly about everything we can do to prevent falls in every area we normally encounter.
Just keep in mind that many falls can be predicted and avoided, but, as I say, only with your help.
And as I say, if you see a resident at risk or observe potential hazards, stop and take action. Make resident safety and fall prevention a priority, and encourage everyone on the residents team to do the same.
Perfect. Stay with me for more simple secrets for effective fall interventions and preventions.
And we'll both tell you how to make a really big difference in helping someone avoid those painful pitfalls.
They will thank you.
You have my guarantee.
Until we talk again.
What did I tell you about interrupting me?
Hello, Dr. Julius Tipover here.
And I am Professor Emma Fallendown with a good day to you and welcome to Pitfalls. Today we'll open your eyes to a fall hazard that could happen at the very moment we start our day. And where might that be?
I'm so glad you asked me, Emma. It's where you normally find everyone in the morning, in bed. That's why the best way to start the day is to stop unnecessary falls in the bedroom. A few simple procedures is all it takes.
As long as you perform them properly.
Fall prevention in and around the bed is really critical to us, and turning in bed is really high on the list. If the patient is too large or difficult to manage, get help from a coworker. And remember, always turn the resident slowly.
But now I will tell you another situation where bedroom falls commonly occur, and it involves using the bathroom.
This is such a common problem. The resident is in bed, needs to go to the bathroom. The staff is busy, impatient. The resident gets up unassisted, and that's a dangerous moment.
Help! Somebody help me!
It's understandable. She doesn't want to wait, either because she really has to go or because she's just plain embarrassed to ask for help. But when residents get up unassisted, the risks go way up. We've found it's best to work on a proactive schedule. For me, that means checking with residents every 2 hours to see if they need to go.
Good. Great.
As you get to know your residents, you'll know who can wait 2 hours and who needs to go more often. That way you can catch them before they have to go in a hurry. That goes a long way in helping to prevent falls.
And don't forget that STOP also means observing the bedroom environment and taking effective preventive action.
Very effective.
There are so many things you can do to make the bedroom safer and more resistant to falling. You can lower the bed height to help the resident move in and out more easily. Ideally, their feet should be able to touch the floor when they're sitting on the edge of the bed. And this really works well for anybody who can't remember to call for help or might be confused and tries to get up a lot. A firmer mattress can also make things better. Socks with non-slip bottoms can also give the resident more stability, then make them feel safer and more secure. And for certain residents, a bed alarm can serve as a useful alert that a resident is trying to get up and needs assistance.
Bed alarms can be very useful, but just keep in mind that alarms can also agitate some residents and may actually cause falls rather than prevent them. It's very important to know how each individual responds to an alarm and adopt a strategy that meets their specific needs.
Very specific.
Of course, no matter how much you plan things, residents standing up from bed may still fall even when you're there with them. They might be dizzy or have a loss of balance caused by changes in blood pressure. This is where it's important again to always stop and think about how you can minimize the risk of residents falling. Make sure you stay by the resident's side as they get up and check that they're steady as they begin to walk. Residents who have a cane or a walker should always use them, even just getting to the bathroom. Encouraging the use of walking aids when you're there will help them remember to use them when you're not.
Good job.
Walking aids are very important, but keep in mind, not all residents know how to use them properly. You gotta keep an eye on residents whether they're using their cane or walker correctly. If I see someone using that incorrectly, I'll refer them to a physical therapist, and then they can have a little, reminder lesson.
So, how do we stop and think about decreasing falls in the bedroom? Let's review. Use safe turnover techniques, set a proactive toileting schedule, adjust proper bed height, assist with standing from bed, and ensure proper use of walking aids.
I must say I couldn't agree more. Check back with me for more simple secrets for effective fall interventions and preventions.
Yes, and we'll tell you how to make a really big difference in helping someone avoid those painful pitfalls.
Very painful.
Very.
To you, Dr. Julius Tipover again, and welcome back to Pitfalls. While Emma is taking a short break in the loo, that reminds me that not every fall occurs while a resident is moving from one place to the next. Many falls occur inside the bathroom. Let's stop and take note of the potential hazards.
Falls don't just happen on the way to the bathroom. They happen once a resident is there, too. The bathroom is a very unique location, especially due to the presence of water. Wet, slippery floors are a major hazard. Check bathrooms frequently to be sure the floors are dry, and consider placing a no-slip mat by the toilet. Physical transitions are often tricky. Getting on and off the toilet can be quite a challenge. If you find a resident is having trouble getting on or off, you should report it promptly. It could be the toilet seat is too low, or handrails are needed around the toilet. Physical therapists can help you answer these questions. It's critical to have the right equipment on hand to keep residents safe during toileting.
So again, you must stop, think, observe, and prevent. Many bathroom falls can be predicted and avoided, but only if you are aware of the hazards. Which steps can be taken to improve safety in the bathroom? Keep floors dry, use non-slip mats, check toilet height, and promote the use of handrails. The key is to make resident safety and fall prevention a priority and encourage everyone on the residents' team to do the same.
I'm back. Are we ready for the next segment?
You'll become a powerful part of helping someone avoid those painful pitfalls. What could be better?
You didn't.
Well, until we talk again.
Good day to you. I am Professor Emma Folland.
Hello, Dr. Julius Tip over here with a warm welcome to Pitfalls.
Today,
That's right. Today, when we look at the times and places where falls are most likely to occur, we want to pay particular attention when residents are moving around the nursing home.
Didn't we talk about this in a...
Residents need exercise. Walking is important to maintain strength, so you want to encourage it. But we must keep a sharp eye out for hazards.
Julius!
So let's move right along to hallways and corridors.
Hallways pose a special challenge for us, and the hazards are significant. First and foremost, hallways should be constantly checked for clutter. Debris in hallways is a tripping hazard. Second, floors must be kept dry. Wet, slippery floors are bad news, and spills should be cleaned up immediately. Safe access should be provided around areas that are waiting for cleanup or have just been cleaned. Decluttering is actually a great preventive strategy in any common area like the living room and dining room. We also make it a practice to report any problems with broken furniture that could lead to a fall.
Many falls can be predicted and avoided, but only if you're aware of the hazards in every environment.
And lighting is another issue. We pay a lot of attention to lighting, especially glare in hallways. Many residents in nursing homes have poor vision, and shiny floors can cause them to trip over unseen objects. I pay a lot of attention to shiny floors and poor lighting, and I report these things right away. Of course, any resident who needs glasses should be wearing them when moving about, and you may have to make sure the lenses are clean. That probably sounds odd, but older people often don't notice their glasses getting dirty, and it makes a big difference in vision. And bifocals can actually be a problem. If a resident is wearing bifocals, you have to take extra care. People get disoriented when their eyes switch between which portion of the lens they're looking through. Single vision glasses, if possible, are going to be safest when moving about.
As always, it is critical to stop. Let's review steps to reduce falls in hallways. Declutter pathways, minimize glare, maintain proper lighting, remind residents to wear eyeglasses, and keep glasses clean. And remember,
if you see a resident at risk or observe potential hazards, stop and take action.
Make resident safety and fall prevention a priority and encourage everyone on the team to do the same. And we'll see you here next time.
We need to talk again.
Dr. Dr. Julius Tipover here.
And I am Professor Emma Fallendown with a good day to you and welcome to Pitfalls. I'm afraid to ask, what's with the dark glasses?
Well, it's certainly not to hide my identity as a renowned expert on typological phenomenon. See if you can guess.
I think I got the idea. Let's all help the good doctor by ignoring him as we look outside to explore why you still need to stop when a resident heads out for some healthy sunlight.
We encourage our residents to get at least 15 minutes of sunlight exposure each day, so the trips they take outside are essential. But we are always on the lookout for outdoor hazards that may lead to a fall. We focus our attention on high-risk areas like steps, curbs, and any uneven surfaces in the outdoor setting. We study and support our residents as they navigate these areas, and we stress the importance of using handrails whenever they're available.
Inside or out, always look for potential hazards, take corrective action, and share what you see and do to maintain a safer environment for your residents.
It might sound extreme, but we even watch for shadows from trees and plants. They often confuse residents with poor vision. Especially watch for clutter, broken furniture, and cracked steps or pavement. And be quick to report what you observe.
So keep these things in mind to stop and watch out for as you work to prevent falls outdoors. Watch for steps and curbs. Look for uneven surfaces. Pay attention to shadows and dark areas. And be aware of cracked and broken pavement.
Help someone avoid those painful pitfalls. They will thank you.
If you don't mind, I would like to have the last word here.
No. Until we talk again.
Dr. Julius Tipover here.
And I'm Professor Emma Fallendown, and welcome back to Pitfalls.
Today, we will finally answer the question that I have addressed in my award-winning book, Shoes and Wheelchairs, to walk, roll, or skip the whole thing.
What award?
That's not important.
But fortunately, the solution to these challenges, which may or may not be in any book I've never heard of, are really the same no matter where you are. And you need look no further than down at your feet.
It's very important that residents always wear shoes when they're up and walking about. The shoes should be their own, and they should fit well. Shoes that fit well create good stability, but if they're too tight, it can cause foot pain and lead to problems with walking. Poorly fitting shoes increase the risk of someone falling. Loose shoes or laces cause trips and slips. If the laces are untied, tie them. If I notice a problem with shoes, I report them right away. And the family can be asked to help get better shoes for their resident. Healthy, pain-free feet are really important. We pay a lot of attention to proper foot care. Healthy feet makes the resident more balanced and makes them more active.
When it comes to shoes, stop and remember. Require shoes everywhere. Ensure proper fit. Report shoe problems right away. And promote healthy foot care.
Moving on to wheelchairs. You would think that a resident in a wheelchair would have little risk of falling. Stop and think again.
Wheelchair falls are a big problem in nursing homes, but common sense prevention makes all the difference. For example, make sure that locking mechanisms on wheelchairs work correctly. They should always be locked when residents are getting in and out of their chairs. If we find a broken lock or other wheelchair problem, we have to report it right away and watch for residents who can't sit upright steadily in a wheelchair or any chair. Special pillows or supports can be used to keep residents stable and comfortable while sitting. It's a mistake to think that residents are safe because restraints are in place. We've seen studies that show that restraints actually increase injuries.
Let's stop and remember key steps for reducing falls in and around wheelchairs. Maintain locking mechanisms. Use locks to stabilize the chair. Report equipment problems. And don't rely on restraints. It's all in chapters 5 through 13 in my book, available on my website, www.tipovershoesandwheelchairs.tip.
Yes. Or you can just stop, think, observe, and prevent. It's the simplest way to maintain a safer environment for your residents. Remind yourself to stop. Look for potential hazards, take corrective action, and share what you see and do with others on your team.
Which is in my book.
You can make a really big difference in helping someone avoid those painful pitfalls.
Yes, chapter 22.
Until we talk again.
Do you think I should repeat the web address?
Good day to you again. I am Professor Emma Fallendown.
And Dr. Julius Tip over here. So, with a bit of help from my colleague here, I've been sharing the many ways you can help decrease the appalling statistics for falls among nursing home residents.
And even though the experience has been personally painful for me, I hope we've shed light on what you can do to help make a big difference. It all starts with STOP, which stands for Stop, Think, Observe, and Prevent.
You're in pain, Professor?
Yes, I am, but only for another minute and a half.
In our job, we need to think constantly about what a difference we can make to the nearly 3.3 million people who live in nursing homes nationwide. What we do on a daily basis to prevent injuries, even death, related to these falls. Think about what that means to the people we serve and to their loved ones.
We do this because we care about the health and well-being of all of our residents. That means watching for fall hazards the moment we start our day and taking corrective action. And then reporting everything that you see and do so that we have a safe environment for everyone involved.
So, here are a few simple reminders of the ways that many falls can be predicted and avoided with your help. To stop and decrease falls in the bedroom, use safe turnover techniques, set a proactive toileting schedule, adjust proper bed height, assist with standing from bed, and ensure proper use of walking aids.
And when it comes to bathroom safety, here are the things to stop, think about, and observe to prevent falls. Make sure all floors are dry, use non-slip mats, check for proper toilet height, and promote the use of handrails.
And keep these things in mind to stop and watch out for as you work to prevent falls outdoors. Watch for steps and curbs. Look for uneven surfaces. Pay attention to shadows and dark areas. And beware of cracked and broken pavement.
Getting exercise by moving about the nursing facility is important to help residents keep up their strength. At the same time, when using halls and corridors, it's critical to stop and remember to declutter pathways, minimize glare, maintain proper lighting, remind residents to wear eyeglasses, and keep glasses clean.
When it comes to shoes, stop and remember. Require shoes everywhere. Ensure proper fit. Report shoe problems right away. And promote healthy foot care.
Don't forget about wheelchairs and fall prevention. Maintain locking mechanisms. Use locks to stabilize the chair. Report equipment problems. And don't rely on restraints.
If you see a resident at risk or observe potential hazards, now you know how to STOP and take action.
And if we all make resident safety and fall prevention a priority and encourage everyone on the residents' team to do the same, we can work wonders. And thank you, Professor, for assisting me with these valuable segments of Pitfalls. By the way, how is your pain?
Almost gone.
So this video gives you many different examples and many different ways to try to help avoid falls in our facility. Fall prevention is everyone's responsibility, not just floor staff, but everyone. So if you see loose flooring, items or clutter on the floor, or spills, it's your responsibility to report it. Pick it up, clean it up. For larger wet areas, notify housekeeping so that way they can get the mop and the wet floor signs and clean it up a little bit better. But you need to do an initial cleanup to help secure the area. So fall prevention is, everyone say it with me, everyone's responsibility. So if an accident such as a fall occurs, there is something that is called a IR report, an incident report, and it's an IR 624. It's required by Department of Social Services, and this is what is required. So in the event that we have done everything that we could to avoid a incident, when you see a event such as a fall, unwitnessed or not, a resident has had a seizure, fights between residents, and I'm talking about fights where there's actual physical contact made between the two residents, or if a resident is sent out on a medical emergency need, Del Monte Assisted Living and Memory Care is required by the Department of Social Services to report this within 7 days. So this form you see here to the right is a incident report. You must fill this out when you witness or come across an incident. When filling out the IR report, you need to print. Please do not handwrite in cursive. It needs to be printed. Fill out the top where it says resident's name or residence if there's multiple residents involved. And then the first section you're going to fill out is describe the event or incident. You include the date, time, location, the nature of the incident, effects that were leading to the incident, and how it affected the client, including an injury. So kind of back to like when we were in school, who, what, when, where, how, and why. Same thing on here. So who it happened to, when did it happen to, how it happened, why it happened, and why it happened. So who, what, when, where, and how, and why. So here you're going to fill in the details. You're going to describe. You're not going to assume. For example, Mrs. Smith reported to me she had a UTI. She was sent out for a UTI. So instead, we're going to say Mrs. Smith reported abdominal pain and requested to go to the hospital. Even though we know Mrs. Smith's history, all of that, we're not going to assume, okay? So we're just going to state the facts. Mrs. Smith reported she had abdominal pain. Mrs. Smith was sent out to the hospital on February 14th, 2022 at 10:55 a.m. Next, you're going to place the names of the persons involved. So if it was reported to you in the med tech, you're going to put yours in the med tech's name. And then you're going to explain what steps were taken. 911 was called. Paramedics came and assessed. Paramedics took Mrs. Smith to the hospital, and so forth. So we're not going to say paramedics said she had a UTI because, once again, they're not healthcare professionals. So you're just going to keep it straight to the point. We're not going to make any assumptions or diagnosis. We're just going to report the facts given to us. You can obtain an incident report from the med tech in the med tech room. It is important that you complete this and give it back prior to going home at the end of your shift to ensure that we can get this into Department of Social Services in a timely manner. If these IR reports are turned in late, Del Monte is found with a fine. So help us avoid fines. We have money for other additional things. And get your IR into us before the end of your shift. And MedTechs, please make sure these IR reports get put into the IR book. Okay, so next we're going to talk about bed sores and bed care. It is extremely important that our residents that are bedbound, wheelchair bound, that we assess their skin on a regular basis. If you notice any areas that are red, swollen, foul odor on the coccyx area or the bottom area of your resident, report this to your med tech immediately. This can also happen on the heels of the foot, their elbows, the back of their knees, and sometimes on the back of the head. These are known as bed sores. Bed sores happen when we fail to turn and reposition our residents every 2 hours. Bed sores can develop down to the bone, resulting in the resident having a non-healing stage 4 wound, which will prevent the resident from remaining in our care unless they go on to hospice care. These are very expensive, painful, and disrupts the quality of life of our residents. It's important to encourage the residents that have mobility issues to get up out of bed for meals. This helps relieve the pressure on the coccyx and the bottom area. So breakfast, lunch, and dinner, our patients who are wheelchair bedbound, we need to encourage them to be up and out of that bed for their meals. Changes in position help promote better blood flow. It is also best not to leave the resident in bed all day long or the wheelchair. So for our residents who can, shift their weight from one hip to the other in the wheelchair, we want to encourage that throughout the day. Encourage them to maybe take a nap halfway through the day for an hour or so and to get back up. It's also best not to leave the resident in a wheelchair all day if we can avoid it. So just really, really, really encourage your residents to change their positions as often as possible. If they depend upon us to do so, maybe set a timer to remind you every 2 hours to go and turn that patient. In a wheelchair individual, you should encourage them to report any pain as well. If you notice reddening or opening areas, once again, I cannot stress this enough, even just a little redness on their bottom, report it to a med tech immediately. Medical treatment from a home health provider may be needed. They might need special equipment. We can also ask the doctor to order gel relieving pads for wheelchairs, pressure, mattresses, and so forth. Individuals who are unable to get out of the wheelchair anymore, it's important to reposition them every 2 hours. You notice I sound like a broken record on this. If we find out that you're not turning your bedbound residents every 2 hours, it can be a written up notification, and it could cause a reason for termination of your employment. Our residents depend upon us to provide all of the care, and many of them stay with us until their final days. And when it comes to their final days, they do end up wheelchair and bedbound. So it is our responsibility to turn them and reposition every 2 hours. This includes in the middle of the night as well. So we are going to watch a video on bedbound care and turning and positioning. This one you're going to learn how to safely.
Registered nurses here with Caring People. So today, in this video, we're going to show you how to turn and position a bedbound patient. Now, why would we turn and position a bedbound patient? As you know, when someone is bedbound, they are prone to develop pressure ulcers. Pressure ulcers is from when you have pressure on your bony prominence. So, and Mr. Jones here would be his spine, his knees, the back of his heels, and the back of his head and his elbows. So the things that you would need for this is you would need, for a bedbound person who cannot turn or help out, you would need 2 people. This is Adina.
Hi.
She'll be helping out. You would need 3 pillows, 2 to tuck under, 1 to tuck under the knees, and you would need 2 regular towels to roll up and put under the heels to keep the heels off the bed. Whenever you turn a patient, even if they're alert, orientated or not, you still have to address them and tell them who you are and explain to them what they're doing. And before you even touch them, you have to let them know that you're going to touch them, okay? So, hi, Mr. Jones. My name is Xavier Edwards. I'm your nurse today, and this is Adina.
Hi, Mr. Jones.
She's your home attendant. She's going to be helping you today. So we're going to turn and position you, okay? Okay, so what Adina's going to do is we're going to turn Mr. Jones on this side. She's going to take the left leg, pick it up and cross it over, and then she's going to take the left arm, pick it up and cross it over. And then she's going to put one hand under the shoulder, and one hand she's going to grab the draw pad, and she's going to roll them over. And as she rolls them, remember, the reason why she's here is so he doesn't fall off the bed. And now you have your 2 pillows. So you wanna roll the pillow like this and stuff it under. Remember, Mr. Jones in real life is gonna weigh a lot more than this dummy. So you're gonna stuff it under. How are you doing, Mr. Jones? Are you okay? Okay, we're almost done. You stuff it under, and then Adina's gonna slowly put them down. And then also sometimes if you have another pillow, you can put it under their heels to keep their heels off the bed. Or sometimes what we do is we also roll up towels and we put it under their heels to keep the heels off the bed, because keeping the heels off the bed will prevent pressure ulcers. Another trick that we do is that we can put a pillow over here too to make them more comfortable. And also we take washcloths, we roll them up, double them up, and put them in between their hands. So when they grab, they can grab it so they're not contracting their hands and so they don't dig their nails into their hands. So this is how you properly turn and position a patient. We're using 2 people.
So you will learn more about turning and repositioning of a bedbound resident on your on-the-floor training. Note that throughout the year, we do have other trainings where we're going to have physical therapists and other resources come in to provide additional training. At any point in time, if you ever have questions about safe turning procedures, please speak to a supervisor. So we're going to watch another video. Here we go. Sorry about that delay.
Do you know what pressure injuries are? Pressure injuries, also known as pressure ulcers or big sores, are a serious problem that can cause harm to you or your loved ones. They are wounds on the skin that often develop over the bony areas of the body from lying or sitting down in the same position for long periods. Pressure injuries can cause pain, increased risk of infection, and can also lead to long-term disability or even death. They can take months or even years to heal, and as they worsen, they can become harder to treat. If you or your loved one is chair or bedbound, there is a high risk of developing a pressure injury. There are 6 simple steps you can follow to help you prevent and manage pressure injuries. Think injury. I stands for incontinence care. Constant exposure of the skin to moisture from urine or feces can cause skin damage and increase the risk of pressure injuries. To prevent skin breakdown, it is important to ensure good personal hygiene. Cleanse skin with water or pH balanced cleanser and dry skin gently and thoroughly after each episode of incontinence. You may also ask your healthcare professional about suitable products such as barrier creams or sprays to protect the skin and suitable lotions or moisturizers for dry skin. N stands for nutrition and hydration. Eating a wide variety of food in moderation and in the right balance provides the nutrients required to maintain healthy skin. If you or your loved one is at risk for developing a pressure injury or has an existing pressure injury, it is important to have enough protein, vitamin C, and zinc in your diet. In addition to fluid from your food, it is recommended to drink 6 to 8 glasses of fluids a day, unless instructed otherwise by a healthcare professional. Being overweight, underweight, or having diabetes also increases the risk of developing a pressure injury and may slow down healing of an existing pressure injury. Speak to a healthcare professional for more advice on diet, weight management, or diabetes control. J stands for Just Move. Moving regularly is important to prevent pressure injuries. If you or your loved one is bedbound, turning should be done at least 2 hourly, changing positions between the left side, right side, and lying flat. If chair-bound, change positions at least 3 times per hour while seated. Examples of such position changes include leaning forward and back, leaning to the sides, lifting the buttock of the chair by pushing upwards, and lifting the feet off the footrest regularly. U stands for Use Pressure Relieving Surfaces. There are many types of mattresses, cushions, and aids that are designed to reduce pressure on the skin. If you or your loved one sits or lies still for long periods, discuss with your healthcare professional about products suitable for your needs. R stands for Reassess Skin Regularly. Checking the skin often will help you detect and treat pressure injuries early and avoid complications. Check skin for unhealthy changes in color that does not go away, such as red, purple, blue, or black skin. Changes in skin texture, such as dry patches, swelling, blisters, or breaks in the skin. Changes in skin temperature, such as warmer or cooler areas of skin. Y stands for You should seek help early. If you notice any skin changes, inform a healthcare professional early. Once a pressure injury worsens, it can become harder to treat and can lead to complications. So remember injury, incontinence care, nutrition and hydration, just move, use pressure relieving surfaces, reassess skin regularly, and you should seek help early. Having a pressure injury can significantly impact both the life of a patient and their caregiver. To help us better understand this, we have with us a caregiver, Madam Tang, to share her personal experience. Hi Madam Tang, can you share with us what was it like being a caregiver to your mother who suffered from multiple pressure injuries?
It was a very tough and long journey. As my mom has problem moving around, as a result, she has developed pressure ulcers on her lower back and her lower leg. It was not easy to care for my mom, especially with the added burdens of the pressure injuries that take many months to heal. To prevent the wounds from worsening, my helper and myself have to frequently turn my mom when she was lying down on the bed. When she was sitting, we have to regularly lift her up. Although she was not big size, but you also take a bit of effort to do that.
Indeed, pressure injury needs a lot of effort to manage and treat, and it is not easy for the caregivers. To better help us understand patient perspective, could you share with us how your mother felt during her journey dealing with pressure injuries?
Due to her medical conditions, my mom was not able to talk about her discomfort or pain. So when I changed the dressing for her, I think I could tell that she was uncomfortable. She would sometimes flinch when the old dressing were removed or when the new medications were applied onto the wounds. I imagine it was probably not easy for my mom to deal with the injuries or the discomfort. If I could turn back the time, I think I would definitely do more to prevent her from developing the injuries.
Could you also share with us what helps you as a caregiver to manage your mother's condition?
The advice from the healthcare professional given to me was very useful for me to manage my mom's condition. I also appreciated their willingness to help me throughout the journey as and when I needed more advice.
Thanks for openly sharing your personal experience, Madam Tang. Would you have any advice for other caregivers?
I would encourage the caregivers to learn more about the pressure injuries and how to prevent them, especially for those with loved ones at high risk of developing pressure injuries. As the saying goes, prevention is better than cure. It is important to make an effort to learn how to prevent pressure injuries and to seek help early if you discover any skin changes.
Yes, the majority of pressure injury can be prevented and the complications can be avoided by seeking help early. We can all do our part to prevent pressure injury from happening to ourselves and to our loved ones.
So our residents depend upon us to help them avoid serious issues such as bed sores. If you've got questions about how bed sores develop or how to help prevent them, please let somebody know. So we're going to talk about the psychological needs of our residents. To address these problems, you should learn more about the psychological aspects of aging and how it affects the elderly. So, isolation, family issues, poor self-esteem, poor hygiene, a history of substance abuse or currently going through substance abuse, or financial anxiety affects the social psychological needs of our residents. What is important is to support them if they're going through any of these things. What is a psychosocial need of an elderly person? Therefore, a psychosocial need of an elderly involves mental, social, and physical needs among the aged. Common social emotional needs involve loss of their own self-worth, self-identity, grief, fear, loneliness, financial constraints, and lack of social network. Many times our residents have been, in a skilled nursing setting, and they've developed relationships with the staff and other residents in the nursing homes. And now they're being rehomed into Del Monte Assisted Living. And so that social network that they have come to learn and know is now removed, and they got to rebuild it. So when you've got a new resident who has moved in, take that moment and walk around with them and introduce them to other residents so that way they can start building other relationships that they may have lost. So particular changes in Meeting individual psychosocial needs is a term used to represent patients and families' mental, social, culture, and spiritual development needs arising from emotional response to their diagnosis, social and physical limitations, and so forth. So sometimes a person can have a stroke, and what happens is they now rely upon others, and their diagnosis can be not in the best light, and they find themselves just losing that sense of self-worth. What are the common social needs in the elderly are they need to feel safe and secure in what's going on in their life. They need to be supported. I mean, a lot of them are going through grief. Maybe they recently lost a loved one. They've lost their forever home that they had before, that they raised their children in. So there's just so much that goes on with our residents that we really need to, be involved and listen to them and sympathize with them and just, let them know that we are there for them. So, what can we do to support their needs? Make them feel loved, make them feel safe, make sure they have enough food, clean clothing, that they get a good night's sleep, that they are occupied, that they don't have to worry about income, and that they don't have to worry about transportation services and so forth. And a lot of times, we don't realize, the basic needs of our residents are just as the same as ours. So they need to be able to form attachments. Let them get to know you. Let them get to know, your passions and your likes and dislikes. That's going to help them maybe find something in common with you and develop a relationship. They need to have a need of control. So offer them options on, what to wear and so forth. They need self-esteem and encouragement and just letting them know, hey, that looks really nice on you today. That's a really pretty color. It brings out the blue in your eyes. So give them some self-esteem, encouragement whenever you can. Let them know they've done a good job for the day. Maybe they hadn't been wanting to get out of bed and get out of their room, and they've been doing that. Let them know that, you recognize their extra efforts to participate in activities and encourage them by saying, that's a great job. How do you feel? What did you like about bingo today? And they need to be able to have increasing pleasures. So do things that they enjoy. Maybe they didn't like bingo, but they like the painting. So make sure they know when painting's going to be again. And then help them avoid pain. If you see them grimacing, if they're, uncomfortable looking, go to the med tech and see if maybe it's time for a PRN medication for pain. And if it is, go back and ask them, are you in pain? Do you need another Tylenol? So, help them avoid pain as well. Mental health is also another psychosocial need. So a lot of times just setting up an environment that includes child-friendly spaces. So encourage them to bring their grandchildren and have their grandchildren sit in the dining room where the TV is, and to be able to watch them play, to be able to watch their grandchildren interact with the other grandchildren. So sometimes it's just simple things in life like that. Maybe push them outside so they can, watch other children play. Maybe their grandchildren are too far, but maybe, somebody else has got their family there and they're all outside hanging out. Sometimes our seniors they like to, reminisce and be able to, see those types of interactions amongst people. And so that's something that we can also do to help encourage them. Assisting the resident with basic needs. So, brushing their hair, putting little lipstick on, putting some perfume on, being able to, let them feel a sense of normalcy can help them with their psychosocial needs. Major psychosocial issues include family problems, depression, anxiety, substance abuse, sexual abuse, and violence. A lot of times we get individuals who are adult protective service cases, and they have gone through some traumatic issues. Understanding where they came from and reassuring them that they are in a safe place and they're not going to be abused no more is one way of, helping them with their psychosocial needs. If need be, another thing that you can do is make a suggestion for a grief counselor, social worker, find social support for them, help them avoid loneliness, maybe by helping them figure out who they could be a friend with. If they're married, maybe their spouse is still living at home, encourage their spouse to come in and spend time with them. Bereavement, if they've lost their spouse, maybe we need to get them in a support group where they can talk about that loss. The other thing that we can do that helps with their psychosocial is, fresh air, favorite foods, a favorite drink, warmth, making sure they are, once again, getting enough sleep. So these are all things that you and I probably take for granted, and our families take for granted, that our seniors and our residents really could use support and encouragement in. So this video is this various stages of our psychosocial need throughout our lifespan. And it's kind of interesting because, the first several stages of a psychosocial development can affect us tremendously in our older years. And so it's idea to know, what someone could have gone through as a child that could make them feel distrusting as a senior. Here we go.
Erikson's theory of psychosocial development identifies 8 stages which a healthy individual should pass through from birth to death. At each stage, we encounter different needs, ask new questions, and meet people who influence our behavior and learning. Stage 1. Basic trust versus mistrust. As infants, we ask ourselves if we can trust the world, and we wonder if it's safe. We learn that if we can trust someone now, we can also trust others in the future. If we experience fear, we develop doubt and mistrust. The key to our development is our mother. Stage 2. Autonomy versus shame and doubt. In our early childhood, we experience ourselves and discover our body. We ask, is it okay to be me? If we are allowed to discover ourselves, then we develop self-confidence. If we are not, we can develop shame and self-doubt. Both parents now play a major role. Stage 3. Initiative versus guilt. In preschool, we take initiative, try out new things, and learn basic principles like how round things roll. We ask, is it okay for me to do what I do? If we are encouraged, we can follow our interests. If we are held back or told that what we do is silly, we can develop guilt. We are now learning from the entire family. Stage 4. Industry versus inferiority. Now we discover our own interests and realize that we are different from others. We want to show that we can do things right. We ask if we can make it in this world. If we receive recognition from our teachers or peers, we become industrious, which is another word for hard-working. If we get too much negative feedback, we start to feel inferior and lose motivation. Our neighbors and schools now influence us the most. Stage 5. Identity versus role confusion. During adolescence, we learn that we have different social roles. We are friends, students, children, and citizens. Many experience an identity crisis. If our parents now allow us to go out and explore, we can find identity. If they push us to conform to their views, we can face role confusion and feel lost. Key to our learning are our peers and role models. Stage 6. Intimacy versus isolation. As young adults, we slowly understand who we are, and we start to let go of the relationships we had built earlier in order to fit in. We ask ourselves if we can love. If we can make a long-term commitment, we are confident and happy. If we cannot form intimate relationships, we might end up feeling isolated and lonely. Our friends and partners are now central to our development. Stage 7. Generativity versus stagnation. When we reach our 40s, we become comfortable, use our leisure time creatively, and maybe begin contributing to society. Our concern is generativity. If we think that we are able to lead the next generation into this world, we are happy. If we did not resolve some conflicts earlier, we can become pessimistic and experience stagnation. People at home and at work are now who influences the most. Stage 8. Ego integrity versus despair. As we grow older, we tend to slow down and begin to look back over our lives. We ask, how have I done? If we think we did well, we develop feelings of contentment and integrity. If not, we can experience despair and become grumpy and bitter. Time to compare us with mankind. Erik Erikson was a German-American psychologist who, together with his wife Joan, became known for his work on psychosocial development. He was influenced by Sigmund and Anna Freud and became famous for coining the phrase identity crisis. Although Erikson lacked even a bachelor's degree, he served as a professor at Harvard and Yale.
So I want you to take a minute and think about that resident who is not trusting. That resident who is always suspicious. That resident who has no confidence. That resident who is always angry. And think about Erik Erikson and his theory. So if our resident is not shown love and support throughout the first 5 stages of their life, it can develop into the issues that they are facing as a resident at Del Monte when we're trying to provide care. They're not going to trust you to come back and meet their needs. They're going to be afraid that they're going to develop an attachment and you're going to leave. There's so much that happens in our lives that affect us when we're older. So when you're dealing with a resident who is just anything but easy and happy-going, think of where they came from and who they are, and ask them questions about their childhood and upbringing. And through the stories of their life, you might be able to tell, why it is they are how they are today. And that's why it's so important to develop consistency and routine and show them that they can trust. And I know for some of us, we come and work and we do it because we got children to feed and bills to pay. But at the end of the day, it's a human life. So you got to ask yourself, if I'm going to be a caregiver or a care provider, am I doing it for all of the right reasons? Not just because I have a financial obligation I need to meet, but am I doing it to enhance and enrich somebody's life and be patient and loving and understanding? And when you take that mindset of being patient, loving, and understanding and getting to know your senior, you are now supporting their psychosocial needs. So just remember, you might be all they have, and not everybody will develop a bond with every single caregiver they come across. So if you're special enough for that one person who yells and screams and is angry at all the other caregivers, but they're as sweet as can be with you, take pride in that. That means that you are supporting their psychosocial needs and not just their physical needs.
Erickson.
So, recognizing the sign and symptoms of Alzheimer's. Scientists continue to unravel the complex brain changes that are involved on the onset and the progression of Alzheimer's disease. It seems likely that the damage to the brain starts a decade or more before memory or other cognitive impairments appear. During this initial stage of Alzheimer's disease, people seem to be symptom-free, but toxic changes are taking place within their brain. There are illustrations of women and other individuals, having a hard time finding words that they once used all the time, remembering dates, losing keys. All of this might seem like common oopsies, I'll find them, I just misplaced them this one time. But they are sometimes in our elderly causes for concern. Damage occurs in the brain of someone with Alzheimer's disease before it even begins to show in early clinical signs and symptoms. For most people with Alzheimer's, those who have had the late onset variety, symptoms first appeared in their mid-60s. Think about that. In their mid-60s, our residents that are now in their 80s and 90s were showing early stages of Alzheimer's, and we just didn't think anything of it. And unfortunately, there has been cases of individuals in their 30s and mid-60s that scientists have identified with Alzheimer's. So with Alzheimer's, there are over 32, 34 different types of Alzheimer's diseases. There's one that is called Huntington's disease. Many people don't realize, but Huntington's is a form of Alzheimer's, and it affects individuals as early as in their 20s. There's been cases and studies of toddlers and younger adolescents developing different forms of Alzheimer's. And so it's a disease that the more we learn, the more scientists are trying to unravel it. The very first symptom of Alzheimer's varies from person to person. Memory problems are typically one of the first stages of cognitive impairment related to Alzheimer's disease. The decline in memory aspect, cognitive, such as word finding, vision, impairments with reasoning and judgment, not recognizing that something is a potential harm or a hazard. all may be signs of early stages of Alzheimer's disease. And for some people, may be diagnosed with mild cognitive impairment. Many times those ones diagnosed with mild cognitive impairment are later on diagnosed with progressive disease of Alzheimer's. Alzheimer's disease progression in several stages. We have from mild, moderate to severe stages. In mild Alzheimer's disease, a person may seem to be healthy, but has more and more trouble making sense of the world around him or her. The realization that something is wrong often comes gradually to the person and their family, and it's memory, poor judgment that leads to bad decisions, like maybe trusting someone over the phone with financial records or resources. Loss of spontaneous sense of we're going to do something and do it right now. Taking long time to complete daily tasks. Maybe mom used to complete her morning routine in a half hour, and now it's taking her an hour and a half to shower and get dressed and do her hair and makeup. Repeating questions. What are we having for dinner? I'm sorry, what are we having for dinner again? What is it that we're going to have for dinner? So repetitive questions. Trouble handling bills or money. We might notice that they're not paying their bills. They're giving money away to people that they shouldn't be giving money away to. They might be having trouble finding their way home. They've lived in their home for 40, 50, 60 years, and they're going to the store and they're calling you because now they're on the side of the road and they're lost and they can't remember how they got there and how to get back to where they need to go. Losing things or misplacing things in odd places. I had a resident who was always sticking her glasses in the freezer. Don't know why, but she'd go into the freezer and for some reason take her glasses off and put them in the freezer, and we'd find them in the freezer. Mood and personality changes. Maybe mom is very short and angry all the time. Maybe mom is all of a sudden withdrawn. Increase in anxiety and agitation. I'll do it. What do you think? You think I can't handle it? What you think I'm an idiot? What? Why? And they're mad. They're angry. And all you did was, hey, mom, do you want me to clear the table? So just things that easily set them off that really shouldn't. Alzheimer's disease is often diagnosed in this stage, but it really takes someone to recognize it. The moderate stage of Alzheimer's is we start to see more of an increase of memory loss and confusion and the inability to learn new things. So even though, we're old and we're getting older, we can still learn and obtain new information. So if, your resident or your loved one is not able to learn and obtain a new piece of information, that is a really serious warning flag. Difficulty with language and problems with reading and writing and working with numbers. So if mom was once loving to read books, maybe she was always writing in a journal, and now she's not doing those things. Maybe mixing words up, like I'm going to go put the laundry in the refrigerator. We put things in both, right? But we don't put laundry in the refrigerator. Shorter attention spans. They can't stay focused. Difficulty arranging thoughts, finishing sentences. Problems coping with new situations. Difficulty carrying out multiple step tasks, such as getting dressed. people report that they were, putting their clothes on inside out, having problem recognizing friends and family. This is a big one. You're not my daughter. What are you talking about? No, my daughter is only 16. You're like in your 40s. You're not my daughter. Even though I know that's my daughter, my mindset is not in the moment. It's in the past. So I might not recognize my loved one. Hallucinations, paranoia. You'll hear people get upset and angry. There's spiders. Did you not see that spider on my? Look, all the spiders. They're everywhere. What do you mean you don't see the spiders? They're right there. They're going to get on me. They're going to get on my wheelchair. And sometimes in that moment, we have to live in their moment and say, okay, let me kill it. All right, I'm killing them. Live in that moment. Don't argue with them. Don't argue with them. Impulsive behaviors such as undressing in inappropriate places, or using vulgar, foul language. We have this problem a lot in the moderate stage of Alzheimer's, where we think Mr. Jones is being a pervert and he's flashing himself to us, right? But in reality, he doesn't have that sense and reasoning of right and wrong. And he just knows his clothes are irritating. Maybe he's starting to develop a UTI and the zipper hitting his private parts is irritating his penis. And so what's he going to do? He's going to remove the clothes to make himself feel more comfortable. He's not doing it to show all the women in the facility his no-no parts. He's just trying to take care of himself. Restlessness, agitation, tearfulness. You'll see that a lot where they cry and they cry and they cry for no reason, and there's just no consoling them. Wandering. They see a door and they're gone, and they're gone in a split second. That's why we have to, make sure, doors are secure, and that, if they're outside of the memory unit, that they're with a caregiver, especially in the late afternoon or evening. This is called sundowning. And you'll see this a lot where they just get a lot more anxious and stuff. Repetitive statements, movements, muscle twitching. Sometimes they'll get, like little, head bobs and kind of little arm movements and stuff going. That's very common in Parkinson's disease, which you might not realize is a form of Alzheimer's. And with Parkinson's disease, they get the little head going, and they're very angry, and they're high anxiety ridden. It has to do with where the disease is at in the brain that is controlling all those motor movements. So with those individuals, when they're getting up to walk and so forth, we want to make sure that they stabilize themselves and they get those muscle twitches under control before they just start to take off and walk. Because what will happen is, I'm moving, I'm going to stand up and I'm still moving, and I'm just going to walk. Remind them, take a minute, let that tremor calm down. Okay, now we're a little balanced, we're stable, and now we're going to walk. And then severe Alzheimer's disease. This is late stage. This is where for a lot of families, the reality of the disease is finally setting in. A lot of times when these stages, this late stage of Alzheimer's disease happens, the loved one goes, "You're not providing good care. Mom is not able to communicate no more. When she came here, she could talk. Why can't mom talk? She's losing weight. Are you not feeding mom? Why is mom losing so much weight?" And we're offering food, we're offering breakfast, lunch, dinner, snacks, favorite foods, and we're doing everything we can to help that person to eat. We're providing them travel foods, foods that they can keep in their hands when they're walking. Especially if they're, excessive pacers, which a lot of them are, they'll just move and move and move and walk and walk and walk. We want to give them travel food. a sandwich, a banana, something they can keep in their hand and they can kind of munch on as they're walking, because now they're burning excessive calories. But hey, you know what? Mom's lost 35 pounds since she's been here. You're not feeding mom. Skin infections. You know, their skin is now more, fragile and frail because they're not eating. And so they become scratched very easily. Difficulty in swallowing. Maybe this is why they're not eating, because they can't chew their food small enough, and when they swallow it hurts, or they choke on it. Groaning, moaning, or grunting. This is a lot where you'll hear them just kind of, make a lot of different sounds, noises that don't make any sense. Increased sleeping. So this is really like towards the end, we're going to start to see that they are very weak, they're very fatigued, they are not getting out of bed as often, and they just would rather sleep. Loss of bowel and bladder control. If they haven't experienced incontinence yet, this is when it's going to hit. And that's when we're going to really need to pay attention and make sure we're, performing good peri-care. We're changing incontinence briefs every 2 hours. We're changing them every 2 hours. We're repositioning them. We're doing all the things. And in this phase, aspiration pneumonia is a very big concern. This is when we want to start looking at thickened liquids. That requires a doctor's order, but maybe we need to put thickener in their water. Maybe we need to give them their water in a spoon where it's just going to be a little bit amounts at a time, and encourage them to take their time at swallowing. Encourage them to take a big breath and cough to help bring up anything that they might have gotten down into their airways. And this is the stage that we start to see them decline. Unfortunately, there is no cure for Alzheimer's disease. What we can do for our Alzheimer's patients is provide support not only for them, but for their family. When someone hits the moderate stage of Alzheimer's disease, is when we want to discuss hospice services. And hospice isn't about making them drugged up where they can't function, but hospice is a supportive measure to help provide the best quality of life, not only for them, but for their loved one. Hospice will provide chaplains, social workers, psychologists, medications, all of that to help support them in the last 2 phases of their disease process. Symptoms of mild cognitive impairment. Remember when I first started talking about Alzheimer's a little bit ago, I said many people with MCI are going to eventually be diagnosed with an Alzheimer's diagnosis. We'll later on in an in-service go into the different types of Alzheimer's, frontal lobe, Lewy bodies, Parkinson's, and all of them, and talk about different care needs for those individuals. If you have an individual with an individual service care plan, an ISP, a lot of the CCAs will identify the type of Alzheimer's and the type of specialized care that is needed for those. But MCI, a lot of times, mom goes into the hospital, mom has a UTI, she's got some extreme confusion, and when it's all said and done, the UTI is gone, but the cognitive impairment is still there. And so doctors will diagnose them with a mild cognitive impairment. And a lot of times it takes an illness, such as a hospitalization from a UTI, to get a diagnosis of the mild cognitive impairment. And the mild cognitive impairment has been there for a while, but now we've got a medical professional who is trained to see and recognize this, and now our resident is coming back with this diagnosis. And we need to do our best to support them in this, and help them develop good habits to maybe help them remember things like such as writing notes that, you know, their daughter's coming or they have a doctor's appointment. Having a routine of putting their items up in the same spot all the time. And if they're having trouble finding a word or they're saying the wrong word, don't laugh at them. Don't humiliate them, but just say, oh, I think you mean the washer. You're going to put your clothes in the washer. I think you got a little confused there, but don't worry. I do that sometimes too, right? So that way they don't feel like, oh, geez, I'm stupid. I didn't say the right word. You know, oh, you know, sometimes I say the wrong thing too, you know. We just really need to support them, and they're going to have a lot of emotions sometimes with this this diagnosis, including disbelief. So we're going to watch a video on recognizing signs and symptoms of Alzheimer's.
Here are your early warning signs. And I'm not going to spend a lot of energy or time on these, but I want to just give you a hint. If I am really, really good at telling you, do you remember do you remember that one time when you were a little boy and I'm telling you these old stories over and over and over, and yet when you try to get me to hold on to new information, I can't do it? Be nervous. Because I should not have more trouble hanging on to important new information than I can access that old stuff. And when you start seeing it pretty regularly, a pattern of it, not just once or twice, but a pattern. You also want to look for having difficulty doing difficult but familiar things, like paying the taxes rather than putting them in a drawer somewhere. Seeking out a financial advisor and then telling him to do stuff that I would never have told him to do, and then claiming I didn't tell him to do that. Taking money and moving it around, and it's like, what are you doing? Well, I needed to move it around. Trusting people, not kind of people I'd ever trust. Sending money to a post office box in Oklahoma, if it's not my habit. Taking all my money out of the bank and keeping it at the house. Inviting people into the house that I don't know to come and fix something. We also want to look at problems not just with memory, because that's not what it's all about. We also want to look at problems where I can't think of the thing that you say, one after the other in a row, and there's a dot at the end. You know, not a sentence, huh? Words. Yes, words. What'd you think I meant? You get such an attitude. Yeah. Now, this woman gave me the answer. Why am I being ugly to her? Because I felt stupid. Because I should have known what it was, and I didn't like not coming up with it. Let me give you another example. Not everybody gets angry. Let me show you another example of this same kind of thing, though. You know, it's the one after the other, and you put them in a thing, and there's a dot at the end. What? Oh, my God. Why couldn't I think of that? No, it's not okay. It is not. Now, I wasn't mad before, but now I'm going to get mad. Why? Because she told me it was okay that I was stupid. Is that what you meant to do? No. Well, that's what you did. I'm sorry. Well, you are sorry. This whole situation is sorry. Well, you are. Yes. You're going to go straight to hell, too. That'll be okay. Now, this is where it feels like, and I'm going to be honest with you, sometimes as a care partner, it feels like no matter what you do, you're not right. It's because this disease makes it so hard for me, because I think I should know something. When I don't know something and you give it to me like that, it proves to me I don't know something that I know I should. I have a PhD, my God, I should be able to think of the thing that it's called. Now, if this just happens when you're exhausted, when you haven't had any sleep, when you're really, really worried, and it only happens every now and then, see, this is the tricky part, because everyone in this room is going to say, well, I've had problems finding words. See, I don't think that's, I mean, you're all, everybody's scared of dementia, by the way. They did this study with older adults, and it used to be, what is the thing you're most scared of? Guess what it used to be? Cancer. Guess what it is now? Dementia. Yeah, people are much more scared about this thing than they ever have been before, because the numbers are going up and people realize how scary this is. So what happens is we start seeing some changes in us. We're trying to discount it. So one of the most common things, somebody says something like, I'm a little concerned. I can't seem to find the things that I want to say sometimes. You know, the things that you want to say to people. Now notice how I used vague terms to describe the thing. You know, the fattles that go one after the other, the fattles. The fattles. Fattles. Do you speak English? No. Well, shit. Now, these are all kinds of behaviors that just sort of as you're seeing them, you're thinking, God, what's going on here? And yet on other times, I'm perfectly fine. I could come up with words that aren't real words. It's called word salad. On the other hand, I might just speak vaguely. On the other hand, I might quit talking. It's real easy for us to sort of think, well, you know, all people do that. Not to this, and you want to think of me. Who am I? What have I done? And if it's not consistent with me, you don't lose your speaking skills with normal aging. You are a little bit more of who you've been, but it doesn't change dramatically. Your verbal linguistics stay the same. You're a little slower, but it's still the same. You have the same vocabulary. You actually have more vocabulary than you've ever had before. But it takes you longer to go find the words. So if people rush you, you will still hear anybody normal aging. Could you slow down just a minute? I'm going to tell you. That's normal between generations. It's also very normal for husband and wives to get on each other about this. Because I'll start, you know, I was going to tell you that so-and-so came by yesterday. Yes, and he stopped and he said he was going to fix it. Can I tell the story or are you going to tell it? This is where sometimes you got to sort of sort out what's normal interactive behavior between people and what feels different. But after you've been around it for a while, you'll start to pick up on it if you're listening and paying attention. Another one is getting confused about place or time. So this is that getting lost driving business. This is getting on the interstate and getting turned around and not being able to think of which exit I'm looking for. It can also be getting lost in my life for a moment. So in a moment, I'm looking for the house I grew up in, not the current house. And so now I get to a place and it's like, God, how did I get here? Because I don't remember the process because I can't hold on to new stuff. And all of a sudden, I don't know why I got here. How did I get here? Somebody brought me here and left me here, and I'm here all alone. Oh, my God, who is this? And I might look at somebody I've known very closely for years, and in that moment, who are you? Who are you, by the way? And you're my wife. You're my husband. Because in that moment, I'm thinking I'm 22 in that moment, and I am looking for the person in the wedding picture. And so what happens is I look at you and you scare me because it's like, oh my God, what are you doing in my house? Who are you? Especially at night. And my daughter is there and it's like, who are you? What are you doing here? Mom, you know who I am. No, I don't either. Who are you? I'm your daughter. Bullshit. I don't have a little girl. I have a little girl, but not anything as old as you. And you focus in on my distress, but what you're not realizing is how scary this is for me. I mean, this actually becomes really scary because in that moment, I'm lost. And so when my grandfather would say, where's Grandma? He in that moment truly believed he was in a place in his time in life that it would make sense that she was there. And when my mom would say, well, Grandpa, of course she's dead. Oh my God. He would grieve again the loss. And yet he couldn't hold on to that loss. So that's not the right answer. That's called reality orientation. We don't do that anymore. That's an old thing. We gave that up. It's not good for people. Worsening judgment. These are things that people are making bad choices. Problem-solving issues. These are people who you can go all the way. Now, this is why I don't think it's a good... Oh, I hear you. So this is what I think we ought to do. Oh, okay. So why are you taking my car keys? We talked about this. Well, I never agreed to that. You did too. I did not. The combination of the memory problems and the reasoning skill problems will wear you out if you actually think it's going to stick. Because you get frustrated because you said, we talked about this already. You remember the talk. I don't. You've got to give up the idea that I hold on to things all the time because I can't. And so when I say, well, this is the first I've heard of it, your gut reaction, your automatic response to that, it is not the first time we've talked about this. You got to quit, stop, back up, Now, I actually want you to practice that. That is an important skill. I want you to stop. I want you to breathe in, purse your lips, and blow out. Now, this time I want you to focus on belly breathing, okay? In other words, abdominal breathing. We're going to get to this and tell you how important this is, okay? Ready? Breathe in through your nose. Blow out. One more time. Breathe in. Blow it out. Now, the reason I just had you do that, that's a new skill for you. It's called breathing. Most of you think you know how to do this, but when you're a caregiver, here's what starts to happen. You start to get stressed in caregiving, and before you know it, before very long, you are actually not breathing out. You are sucking air in, and you are holding on to it, and you're only using the top third of your lungs because you've got issues. There are issues. Every time I go over here, there are issues, and I don't have time. When am I going to have time to do anything for me? I am stressed out. Let me tell you something. And what you don't realize is you're not breathing. You're sucking air in, but you never let it go. And letting it go is an incredibly important skill, both in how you deal with things, but also in just simple breathing. So they did a study. They did a study of people who are caring for people who have dementia. And they looked at them, and they compared them with people who were not caring for people who had dementia. And guess what they found out? These people, that's a signal. It means we've almost spent about 45 minutes already. Okay? Let me check in. Have you learned anything yet about dementia that you didn't know? Some of you, yes, some of you not. How about some new skills? Well, you're learning one right now. And are you having some fun? Okay, well, good. Okay, well, then we're coming along. We'll see what we can do with the rest of this period of time. All right, so they did this study. And what they did is they compared people with dementia who were caregiving for people with dementia and people who were not. And what they found is people who were caregiving for people with dementia had cortisol levels, negative stress hormone, that's 50% higher than the normal person. Now, cortisol is a negative stress hormone. It's not good to have in your system for long periods of time. It's really a good thing to have if you're being chased by a tiger and you want to get away from them really quickly. But if you're not doing that, you don't really want to have high cortisol levels, because high cortisol levels increases fat distribution in your organs and around your middle. It makes it very difficult for you to see the big picture. It actually causes your vision to go like this. It keeps your brain from working really well in decision-making tasks. You cannot make good decisions when your cortisol level, because it's a panic. It's sort of got to make you got to do something. You got to move. You're not able to see the big picture and sort of make good decisions and choices based on information out there, because you can't handle all that. It also raises your blood pressure, your heart rate, your blood sugar. Therefore, people who are caregiving for people with dementia are more at risk for developing dementia themselves. Oh, yeah, that's not good. We don't need more people with dementia. There's plenty. So here's what we want to do. They did a study and they said, okay, well, you guys are super stressed. Guess what caregivers said? Oh, good. Something else I'm not doing right. Great. Well, what am I supposed to do about that? I don't have time to get done what I need to do. How am I supposed to deal with stress in addition to that? And so they said, okay, well, we need to make this simple. Let's have them breathe. So they actually did. They had them stop 5 times a day and take 3 deep cleansing breaths. And they actually gave them a kitchen timer to put on their belt. Because guess what happens to caregivers if you don't give them a timer to remember to take care of themselves? They won't. You people don't take care of yourselves. You say, oh yeah, I'll get to that sometime. But you don't. So 5 times a day they would stop and they would do those 3 deep cleansing breaths. And after 6 months they remeasured their cortisol level. It was back to normal levels. What does that mean about you as a caregiver? You are carrying an incredible burden around and you don't even realize you're not even breathing well. You are going into situations, and I'll tell you how you walk in the house for the person. Hey, Dad, how are we doing today? You going to be ready to take a shower? Okay, let's not fight, Daddy. You're filthy. This is going to go real well, I can tell you. Just don't go there. But notice what I wasn't doing. I'm not breathing. And unfortunately, guess who picks up his cues from me? Daddy. And so now daddy's getting more and more tense and more upset. What is it you want to do? And before you know it, you two are going at it again without even realizing how you got there. Okay? We've got to change our behavior so their behavior will change. But it's only going to happen if we're the ones who change first. We've got to be willing to make that shift. So breathing regularly, really, really important. So when you can think of nothing else to do, step back. You're not wanting to take a shower, I hear you. It's a much safer response. It's a response, not a reaction. You're actually thinking about what you're going to do. You're taking that moment to get yourself together before you try to help somebody else. You know what they say about that oxygen mask? Well, it's the same thing when it's caregiving. You've got to move out of caregiving to care partnering. So it means you have to think. Now, we can go over the rest of these, but I don't want to spend a whole lot of time. I do want to point out a couple of other things here, though. The loss of initiation. That's probably one of the ones that gets missed the most. Loss of initiation, it means I'm not doing things like I used to. I will talk about it, but I don't do it. So let's say I used to be very active in my faith community. I used to run a group of adults, and we do study. And now I've said, well, you know, I'm not going to do that anymore. That I have given them a lot of time of my life, and I let somebody else step forward. Let somebody else do this kind of thing. I'm just not going to do it. Or I'm not going to go to church this Sunday, or I'm not going to go to temple this Sunday. I'll do it another time. I'll do it another time. I'm going to clean that up. I'm going to clean that all up. I'm going to get in that room and get it all dealt with. And not a thing gets done. It could be depression, but it might not be depression. It might be the first signs of dementia. Because one of the things that their brain can't do is figure out how to go from a thought to actually doing it. And so they get stuck. And so you get home and it's like, Mom, you didn't even eat the sandwich I left you. Well, I just wasn't hungry. It wasn't about being hungry. It's about not being able to get started, not being able to figure it out, not being able to know what to do first, what to do next, to sequence through it. This is where you go in and you see the bedroom, you're like, what have you done? Well, I was going to put it all away. It's all out. I know, I was sorting it. You were not. And so you're frustrated because every time you turn around, I tear things up in my effort to be helpful. But I don't see it. I'm trying to do it, but I can't figure it out. I start looking at all the piles, and then I get sort of flustered, and I don't know what to do. I don't know. I'll get to it. Just leave it. Leave it. Don't mess with it. I'm coming back to it. But I can't do it.
So, if you guys notice that when you're in memory care, some of the rooms look torn up, right? And it very well could be that that resident has that thought process of they're helping, right? They're going to reorganize, they're going to put away, they're going to move it. And in return, they're making that mess, right? So their thought process isn't there. One of the reasons why I picked this episode was not only did they talk about the signs and the symptoms of Alzheimer's and dementia and what happens and how the conversations may go, but what happens to us as caregivers. You guys, when you're in the memory care, have probably the most stressful parts of a day, right? Because you have to reason with someone who has lost their sense of reasoning. You have to keep somebody safe who doesn't understand the danger and it still has their curiosity of what this is. And so throughout your day, remember that sometimes we have to live in their world and agree. And sometimes we have to remember to redirect and distract. And we have to remember for our own well-being to stop and breathe. So understanding unusual behaviors and memory care. So not all people with dementia will engage in challenging behaviors. Some are very pleasantly forgetful and they're easygoing, and others will gradually become more forgetful of their awareness and be able to not have that sense of making decisions. And it is likely, though, that you are caring for a resident with dementia, you will witness some or the following types of challenging behaviors. So, physical or verbal aggression. With the verbal aggression, it's really sometimes hard not to take it personal, but just remember that they're not probably frustrated with you, but frustrated with themselves in the situation. Physical aggression, we need to do an incident report, especially if they hit another resident. Now, if they've hit a staff member, we still do a report, but it's an internal report. Physical and verbal aggression is something that we want to chart in their charts, so that way when we pull families in and if we have to get them more involved, to get them more involved with their neurologists and stuff, we can give them examples of times and days. Also, documenting it will help us maybe identify patterns that is causing this aggression. Agitation in the form of restlessness, emotional distress, or pacing. So when you go into the memory care unit, most of the residents are really up and down the halls all day long and they're pacing. And we have, one, I can go in there and she'll see me and she'll cry. She's always just in an emotional state of distress. And she's restless in her distress, and it just happens to be part of the disease process. Episodes of delusion, and they're very, firm in their belief. We have one, every once in a while she'll be very insistent that she sees her son on the other side of the doors, the glass doors that go to their outside area, and she's very insistent that we let him in. And so sometimes it's just simple as saying, okay, Mrs. Smith, I'm going to hold your hand. We'll walk down there and, we'll let him in. And we'll get to the other end of the hall. And of course, her son's not there. And so then she gets mad because he lost patience and he left, right? We took too long to get down there. But I lived in her moment. I agreed with her and we walked and went to go let him in. And that helped. Also, they have sleep disturbances. A lot of residents, they lose the sense of day or night, and they will be up all night long and sleep all day long. And that's why it's really important during the day we open the windows and we let the light in to help them recognize when it is daytime and when it's nighttime. Random wandering from one place to another. This is, for our residents that are maybe in the early stages and they're not in the memory care unit yet. And we're starting to see them kind of maybe go upstairs, downstairs, inside, outside, and they get lost and confused and turned around. Those are the ones that we might want to have reevaluated for potential locked memory care or transverse care, pull them from the assisted living floor. Withdrawal from things that they love, empathy, and sometimes hoarding. Hoarding can be a sign of an Alzheimer's behavior. I had a friend who couldn't figure out why all the forks and spoons in her facility were going missing. And then somebody reported to her that Mr. Alex got excessive amounts of forks and spoons in his room. And Mr. Alex had been hoarding probably a good 6 months worth of forks and spoons in his room and was running out of space to hide them. And the caregiver happened to see them kind of sticking out of a box one day that he was very secretive about. And when they started going through his room, It was a lot of like other things that he was collecting that didn't belong to him. It wasn't a big items, but there were enough items to be underneath that hoarding category. So they'll start to collect items and take things into their rooms that aren't necessarily theirs. And so we just have to, when they're not looking, sometimes is rehome those items. Because they lose their ability to express themselves, people with dementia often use behaviors as ways to communicate. So if there's a new aggression, they might be telling us that they're not feeling good. So we need to pay attention to that. When you observe a behavior, ask yourself why they might be acting this way and what could be the trigger. Maybe they see someone who reminds them of someone from their past and they're afraid. So we want to be on the alert and look for these types of triggers so we can learn how to help reduce them and help manage that behavior. And it's important to remember that you can't use reason or logic to convince someone with dementia to behave a certain way. Instead, find ways to decrease the intensity or frequency of the behavior. So maybe, them eating, in the dining room, throughout the whole mealtime is overwhelming and overstimulating to them. Maybe we need to bring them in halfway through mealtime so that way they're not exposed to the large group for a prolonged period of time. Maybe not bringing up items that could be a trigger or reminding them of their loved one no longer being alive. Yes, your mom's gonna come pick you up, honey. I think she said she's run a little bit behind. Agree with them. Don't argue with them. You're 90 years old. Your mom's not. If your mom was alive, she'd be like 130. Don't do that. Just live in their moment. Sometimes they're just wanting to be helpful, and their mothers and school teachers and they just want to be useful, and they're in that mindset. So maybe give them some towels to fold, laundry to fold. Allow them to put their own laundry up, because in their mind they're a mom, and what do moms do? Moms take care of people, right? So find ways to help reduce the agitation as well. Try these approaches. Try not to get angry or upset or take their behavior personally. They are not acting this way on purpose. You'll hear it all the time. Mom knows better. Why is mom doing this? Mom doesn't know better. She's lost that sense of reasoning. Kind of think of it sometimes as, when you're raising your smaller kids, toddlers, and they don't know the difference from right and wrong. It's the same thing. Our memory impaired seniors, they've lost that right from wrong. So just be patient with them. Speak calmly and softly. Sometimes a soothing touch can reassure them that they're loved and they're safe. Sitting down at their eye level when you're talking to them will sometimes help. If they're sitting down and they're crying and they're screaming and you're standing over them and you're, talking to them, it can feel very intimidating. So sometimes being at their level will really help. If the behavior is aggression, back away. Give them their space. Let them feel that anger. Don't argue. Think about what the potential cause was. Are they hungry? Are they tired? Are they in pain? Are they frustrated? Are they lonely? Maybe their daughter just left and now they don't know anybody here, and why am I here, and now I'm angry because I'm all alone. Am I bored? Give me a book. What's my favorite TV show? Read to me. Do something to keep me distracted from that feeling. Could it be a reaction to a new medication, a side effect? If your resident has recently been to the hospital or a doctor's appointment and there's a new medication on board and they have a new behavior, report it. Report. Remember I said earlier, report the behavior. and respond to the emotion, not the behavior. Avoid using reason or logic to explain. Just say, I understand, I get it, be there and support. Don't tell them they're wrong and their feelings. So this next video is also done by the VA, and it gives some great examples on how to handle different aggressive behaviors. It says the veteran, but we all know that means our resident, but it is a great example on how to provide support and approaching of our care and our residents.
Caring for veterans with dementia can be both rewarding and challenging. The VA has developed this training program to help you adopt a more positive approach to address veterans with dementia. In the following scenarios, you will first see a counterproductive way of approaching a veteran, followed by the preferred positive approach of engaging the veteran and addressing challenging behaviors. By learning these positive skills and techniques, you will not only experience better outcomes, you will honor veterans in the twilight years of their lives.
You haven't changed yet? Looks like we've got work to do. Let me get some things to pretty you up. Okay, now, where to begin? No, stop! No, stop! That hurts! I'm just brushing your hair, no big deal. That hurts! Ow! No! Hello, Mrs. Jones. I'm Angela. Looks like you're ready to get your day started. Mrs. Jones, would you like to fix your hair and put on some makeup? Okay. Great. Let's just walk over here so we can find your hairbrush. Here, your hairbrush. Some lipstick. What would you like to do first? Do you want to brush your hair?
Yeah.
I like how you're fixing your hair. It looks real nice. What's next? That color looks good. What would you like to do next? Sure, you can add a little blush. That'll add nice color.
Grooming tasks can turn into a major hassle or be a source of pleasure for veterans. Approach and cueing make a big difference. Systematic cueing involves giving step-by-step cues, increasing assistance as needed based on the veteran's response. See how the staff member begins with visual and verbal cues, and then, only when necessary, employs tactile cues. Visual cues are typically easier to process than verbal cues. Angela also uses hand under hand to get the veteran's attention and guide her to a place that is more familiar for grooming, such as a mirror and sink. Notice how the staff member uses hand under hand for grooming tasks as well. It allows the veteran to be more engaged and lets the staff member know early if there's a problem. Giving positive feedback to the veteran's choices also keeps Mrs. Jones engrossed in the process.
Morning, Mr. Hughes. Time to get ready for the day. Need to get dressed for breakfast, right? Eggs and sausage this morning. Let's see what we got in your closet. This'll work. What you think, Mr. Hughes?
No, stop.
Hey, stop. Come on. I need you to settle down now.
Stop.
You want to get dressed, don't you?
No,
stop fighting me.
Stop.
Good morning, Mr. Hughes. Oh, I forgot. You prefer Willie. I'm John. I'll be helping you today. I see you're already awake. Great. Can I help you with anything before breakfast? Maybe we can start with changing your clothes. Let me help you up. There we go. Good, Willie. All right, almost there. Good. All right. Let's see what you have to wear. Which shirt do you like? Do you want this one or this one? Which pants? This one or this one?
This one.
Nice choice. What's next? Let me help you take off your PJs. Let's start with your button. Thank you for helping, Willie. Start with your right sleeve. You're doing great. It's hard with arthritis. Okay. Your right hand. Good. Thank you. I like this shirt on you. I really like the color. There we go. Good job, Willie.
Thank you.
This vignette demonstrates the value of the initial approach as you engage with a veteran. As you saw in the first scene, John was not able to establish much of a connection with the veteran. Willie remained upset throughout the interaction. In the preferred approach, John engages Willie using the positive physical approach. It's important to start some distance away, maybe 6 feet. Lift your hand to your face like saying hi or hey. Drop your hand as you approach, keeping the palm open. Pace yourself slowly. Take about a step per second so you don't startle the veteran. Stay to the side of the person at arm's length and accept the person's handshake. You also want to get down to the person's eye level without leaning in. Once you have made the connection in a supportive stance, offer the minimum assistance needed. In the preferred approach, John also uses fewer words because people with dementia may have trouble processing verbal information. He provides the veteran with simple choices and opportunities for the veteran to participate in the activities, consistent with the veteran's level of cognitive function. John also uses the veteran's first name, Willie, instead of Mr. Hughes, because the staff have assessed that is how the veteran prefers to be called, by his first name. By following these steps, you engage the veteran, respect their choices, and increase the chance of a positive outcome.
Hello, Mrs. Jones. Look at you, still haven't touched your food. Well, let me feed you some lunch. Here we go, just mixing it up. No. Take a bite. Yum, isn't that good? Come on now, you know you need to eat for strength. Hey, Jasmine, you must be done checking vital signs. Looks like I'm going to be late to the staff meeting. I'm still with Mrs. Jones, who is taking her sweet time with lunch. Come on, honey, hurry up. Mrs. Jones. I'm Angela. May I join you for lunch? Lunch looks pretty good. We have soup, salad, chicken, and dessert. What would you like first? Let's try the soup first. Will you pick up your spoon? Were you trying to have some soup? Here it is. Let's try it together. Looks like you enjoyed it. You ready for another sip? Looks like we can keep going.
Veterans with dementia retain more abilities than many may realize. Your approach and nonverbal behaviors can make a big difference. Because abilities can vary day to day, you should assess the veteran with each encounter. In the second scene, the staff member uses simple questions, directions, and systematic cueing to figure out what level of support the veteran needs. Rather than simply feeding her, the hand-under-hand technique provides a better eating experience as you help the veteran become more engaged with eating. Watch how well this hand-under-hand positioning works. Make sure to approach from the veteran's dominant side. Offer your hand palm up. Slide your thumb next to theirs and wrap your fingers under their wrist. Then use your fingers to grasp the spoon or other items. You may need to adapt for veterans with a hand deformity or dysfunction.
Have you seen my mother?
No, I don't believe I have.
I need you to help me find my mother.
Remember, I told you I have not seen your mother. I don't think she knows you're here.
I need my mother. You're not my mother. Get away from me. Where is my mother? I need my mother. Have you seen my mother? I need my mother.
You look upset. Can I help you?
I need my mother. Do you know where my mother is?
Let me come around so I can help you, okay?
Yes.
How about we go look in your room, okay? You're okay. It's all right. You're all right. Here we are, back in your room. Do you have a photo of your mother so that I can see what she looks like? Oh, I wonder if she's here. Oh,
yes, Mama.
What a wonderful picture. You all look so happy. Is this your mother?
Yes, Mama.
Look at that beautiful background. All those flowers. Thank you for showing me the photo, Willie.
Thank you.
Tell me, what are some things you enjoyed doing with your mother?
Oh, Mama taught me how to play the piano.
Really?
Yep.
Would you play a song for me?
Oh, I'm not that good anymore. I can't play.
Oh, I bet you're better than you say. Let's go to the recreation room and find a piano. I'd enjoy hearing you play. Which way is the rec room again?
This way.
Uh-huh, you're right. Yeah, let's head this way.
In our first example, you saw how quickly a veteran's distress can escalate and become out of control. That's because veterans with dementia often cannot tell you exactly what is wrong. So it's best to follow these steps. Show the veteran you share their concern. You will need to do some detective work to figure out the underlying problem. And stay positive. Send the message that you can help. Also, see how the staff member uses positive physical approach skills and hand-under-hand technique to guide Mr. Hughes to a more familiar activity that he thinks will reassure the veteran. These skills also allow the staff and veteran to make a connection without confrontation. Notice how John also engages the veteran with positive verbal interactions as he works to redirect the veteran to a less distressing topic. The veteran is able to enjoy family memories, play the piano, and use abilities not yet affected by the dementia. All of this turns what could be an argument into a more gratifying outcome.
We took a trip to D.C. and we toured inside the Capitol and the Lincoln Memorial, all those museums downtown. Oh, grandkids. Oh, they wore me out. But it was a good trip. It was me and my family. I never realized that Lincoln Memorial
Excuse me, Mr.
is
Smith,
just-
can you stop for a moment? Mrs. King is having a difficult time. Jamal, I need some help here. What's wrong? Are you angry? Do you want to leave the room?
Hey, how can I help?
And just help me get her out.
Yeah, sure, no problem.
No, let me go.
Hey.
We need more help here. Hurry. Call the charge nurse.
Hey, Miss Rossington, can you get out here, please? We need help.
Mrs. King, settle down. It's okay.
Come on now, you okay?
So let go.
Hey.
We took a trip to D.C. and we toured inside the Capitol and the Lincoln Memorial, all those museums downtown. Oh, grandkids. Oh, they wore me out. But it was a good trip. It was me and my family. I never
Excuse me,
realized that
Mr.
Lincoln
Smith,
Memorial.
can we pause for a moment? Mrs. King is having a difficult time. Jamal? Can you take over the group while I help another veteran?
Oh, sure, no problem. Hi, guys. Hey, once things get settled, we'll start again, okay?
Would you move over one chair? Are you upset? What's bothering you? Walk with me and tell me more?
Now, where were we?
I was just telling them about the trip to D.C.
Hmm.
Oh, and the Lincoln Memorial.
Thank you for coming with me. Is anything hurting you? Maybe a snack? It's a good idea. Would you like an apple or Jell-O? Yeah, some fresh air sounds like a great idea. Let me help with the door. Why don't we sit there for a minute, then we can have lunch?
Okay.
That was a good idea to come out today. Such a nice day.
Feels good here.
Often, veterans who are distressed cannot tell you what is wrong. You see how quickly distress can escalate when a veteran is confronted or overwhelmed by stimulation. It's best to attend to the distress away from the group. If you find yourself in a group situation where a veteran becomes distressed, get help so you can address the distressed veteran in a one-on-one manner. Then use the same techniques as shown in the previous scene. Let the veteran know you share their concern. Do some detective work to figure out the problem, and send a message that you can help. Notice how Gloria involves staff member Jamal to lead the group, while she attends to Mrs. King. Without disrupting the group further, she guides the veteran away from the group so she can figure out what is wrong. At the same time, she provides the veteran an opportunity to move away from an overly stimulating environment. Gloria uses positive verbal interactions and acts on a series of hunches about common unmet needs, like pain or hunger, until she picks up on the veteran's cue that she wants to go outside. For veterans in distress, use positive physical approach and hand-under-hand technique. These skills allow the veteran and staff member to make a connection, feel on the same side, and tuned in to cues on what underlies the distress. You turn a difficult group situation into a positive outcome and provide our veterans with excellent care.
What the staff were doing is getting on the same level as the resident. They were eye to eye, they spoke calmly, and they also provided them opportunities to make their own decisions. So I hope this video will help you guys when you get into these situations to know how to handle them. If you need more training or additional resources on this, please let us know.